Okay, we're going to talk about several different things. And the first thing I wanted to talk about was just go over what capnography is and why we should use it. And there's really not a lot of slides, so stop and ask questions anytime. The difference first between oxygenation and ventilation. We all know what oxygenation is and how to use an oximeter and what it does. But the oximeters take a few minutes, up to 5 minutes, to show changes. When we drop the oxygen or increase it, we always wait for a little bit and we go back and we see what that change is going to be. Where the difference in capnography is, it can reflect the change in ventilation just within a few seconds. So the capnography is going to make a measurement of your exhaled CO2 at your end of your breath. Those are the two differences. So ventilation by the end of your tidal volume, or when you exhale, that's when it takes the measurement. It gives you a breath-to-breath measurement, and it can change within seconds. It's not dependent by motion artifact as the oximeter is, or cold fingers, or on and on. The normal is 35 to 45, which is the same on the blood gas. And this is a really important slide because nothing we do can we stick on a patient or do to a patient and only look at one thing, look at one number. The CO2, the end-tidal CO2, it depends on ventilation, if you've got the air moving. And in asthma, COPD, edema, a different reason why there's not air going in, that's going to affect it. Diffusion, when you breathe in the air and the oxygen and it goes down into your lungs until the alveolar level, when the oxygen has to go across the membrane and CO2 has to come back out. CO2 is a waste product of respiration. So as you exhale that, all these different things affect how we're measuring that CO2. Perfusion, if any blood flow, the blood, where the oxygen is carried by the blood, if there's a reason why the blood can't get to the alveoli, then it has to go across the membrane. So it could be disease, it could be poisoning, it could be all those different things. So the number's not absolute, and when we breathe in a breath, our lungs don't completely, healthy lungs do. More or less, they fill up like you're filling a jug. The oxygen goes in, the CO2 and the other gases come out. But for different problems like pulmonary edema, there's fluid in the alveoli and the oxygen and the CO2 can't change places. Maybe there's a pneumonia or asthma where part of the lung is not being ventilated. So that's going to make a difference too. The two ways that we can measure capnography here, and also the third way would be in surgery with the anesthesia machine. But we can do it through a nasal cannula, and we can also do it through an adapter when someone is intubated. These are the two different monitors that we have, and I'll go over the monitors. This monitor here, each unit has one of these, and this is, we have a lot of questions about alarms and the correct way to use this, and the sales rep is coming in next week and giving us an in-service on that. The monitor on my right is hooked up to the Space Labs cardiac monitor, and there are two of these in ER in rooms 1 and 3 that they can be pulled out just like your blood pressure cuffs or your cardiac monitors. They can be pulled out as just part of the cardiac monitor. When you push that in the screen, you'll have another line that shows up. You'll have heart rate, respirations, and then this will show up as CO2. There's one of these on 2 South. I got this out of room 215. So if your patient is in a room with a monitor, you can use this. And then the other thing, the Co2 indicator after someone is intubated, that little adapter just shows that there's CO2 in the airway, that it's not in, it gives us another indication that the tube isn't in the esophagus. So that's not going to measure CO2, it's just going to change colors. It's a quick little check after the tube's down, just to show that there is CO2 present. And why measure ventilation in non-intubated patients? The main reason that we would use the cannula and have an idea about the CO2 is if somebody is hypoventilating, whether that's drug-induced or the conscious sedation, PCA pump, anything that we're giving a medicine that could cause the patient to hypoventilate or breathe shallow or less breaths, or if it's a drug or an alcohol problem. So for capnography, you have waveforms and you also have a number that shows up. For the purposes that we use capnography here, our portable monitors, this doesn't print out, so we're only using this to get an idea of what our conscious sedation patients are doing. You look at the patient, it gives you a number to go with what you're seeing. I've given my patients on the PCA pump. They seem drowsy. They are having trouble coughing. Then this will give you a number to say, oh, my end-tidal CO2 was in the 30s and now it's in the 50s, so we've got a problem. Does that make sense, or am I explaining that very good? Mm-hmm. Okay. When we use this, we're looking at trends. We're looking at averages over time. We're not looking at, okay, my number's 38 at 10:49, and my number's 42 at 11:15. We're looking at our patient, we're evaluating our patient, and we have a number to go along with that evaluation to how well we think the patient's breathing. My patients came back to 2 South, and their O2 sats were 90%, and their end-tidal CO2 was in the 40s, the low 40s. Well, 2 hours later, the O2 sat's still in the high 90s because that's ventilation. That's oxygenation. That's not ventilation. But now my end-tidal CO2 is in the 50s or 60, and my patient looks drowsy. They're harder to wake up. They don't want to cough. So the waveform, we're not really going to pay a bunch of attention to that, but I'm going to explain that to you. If we were in an ICU or the patient was in ER for hours and hours, you can really look at the waveform and get a lot of information from that. Not as technically as you can in EKG, where tiny little changes are going to make a difference, but you can get some information. The squiggly line on the bottom shows what a normal end-tidal CO2 waveform would look like. So, and then from A to B, as we're looking at the beginning of exhalation, the patient's just starting to breathe out, and at the very beginning, they're not breathing out from a deep breath. It's just what air is coming out like I'm talking. So all that talking CO2 is not exchanging. And we call that dead space. And dead space, the reason it's dead space is because there's no gas exchange. Dead space, when we put someone on the ventilator, we're adding extra tubing to how they exhale. So we take that into consideration. The second part is, as you can see in the picture, some of the air is mixing with the CO2, and the breath continues, and that breath, the numbers go up real quick, and you can see that air has been involved in gas exchange. So what we measure when we measure end-tidal CO2 is at the end of the breath, the end-tidal, and it's an alveoli plateau or an alveolar plateau. The gas exchange has taken place at that end of that breath real quickly. Does that make sense? then the next part of it is they're starting to inhale and they go back to no gas exchange. There's different conditions that causes the waveform to change, but you can also go by your numbers. There's a normal waveform at the top. When you hyperventilate, you're breathing faster and you're blowing off your CO2. Have the patient breathe into a bag so they can increase the CO2 that they're they rebreathe their CO2. So if you breathe fast, then your CO2 is going to go down. And if it's just it's an inverse ratio. If you breathe slow or shallow, the CO2 goes up. So the hypoventilation, you've got a higher number, and they're slower. You can look at big, slow breaths versus hyper or normal. And then bronchospasm, it takes, the air is trapping in there. So that's going to be a different waveform. That's it for that. But I wanted to go over the monitors, of course. Send your questions, ladies and gentlemen. Okay. You could use it in any of your monitored rooms, and it's also in ER. They have 2 of these monitors, and you can take them out and move them around. The supplies for this are in ER, but I've got the ordering information to give to Mindy, so you can order these for 2 sal, or you can just borrow one from ER, however you decide to use it. This particular one just has the CO2. It's just a cannula, and the other product that we have down in ER is there's a split here, and one tube goes to the flow meter and the other one goes to the CO2 monitor. So this one just has the one. So you can give oxygen and monitor CO2 with one cannula if you want to. So the other one has two tubes. And this is disposable like everything else in the world, and that just plugs right in there. As soon as you push this in, the monitor, just like your other modules for blood pressure or heart rate or anything, this comes on. It might ask you to calibrate, and then you just follow the directions on the screen how to do that. So, easy peasy. I don't know if anybody wants to see that. There's just a little tiny thicker part here on this one for the reservoir for how it monitors exhale. Of course, it's not going to do quite as well with someone that breathes through their mouth. But these monitors seem to work better than the other portable one. The issue with the portable one is the alarms. I mean, they work, but it's the alarms. There's just so many nuisance alarms that people have problems with it. So if you had a patient on 2 sal and you wanted to use this monitor that was alcohol poisoning or drug problems or their PCA pump, or you could have them in your monitored rooms, and this would show up right out at the desk. So that might, that's an option. Do you guys want to see this, or it looks plain? Looks okay? Okay. Easy to see.